today we are advancing to chapter 4. You've already heard a lot about the first half almost of the book. I want to quickly say that this podcast season in the spring 25 is fully sponsored by 5P Healthcare Solutions. I'm the CEO and founder, and we're focusing on what we're writing about, books. But in short, it is to help all actors of the 5P value chain, patients, provider, pharma, medtech, life sciences, payer, and policymakers, the five who have to tango to deliver and co-create value and outcomes and results that really matter by carving out all the no value, low value, wasted healthcare delivery. And it's now my pleasure to welcome Kaitlyn Masters, because that's what we're going to talk about a little bit. Welcome, Kaitlyn, to the podium.
Thank you, Verena. Incredibly excited to be here today and discuss the next tango and the chapter we co-authored together on the payer.
Wonderful. I think, as we did with most of our other co-authors, and I think this is where it really is most of the fun for Hannah and I, because now we have all you guys as real expert leaders in the field. And I want to say that Kaitlyn is, I guess, an international person at heart. She lives on various continents. I think we can disclose one is the US and one is Europe, and maybe you tell us more. But I think what today the essence is, and why I love working with Kaitlyn, and we love working with Kaitlyn, is your real expertise on what we call, in short, value-based contracting, but more largely really how can particularly payers and providers really partner. And I'll talk a little bit about the pharma piece later at the end of the podcast. But Kaitlyn, tell us a little bit more also. Writing a book, what a nightmare, I can say. So what convinced you to embark in this incredible journey?
Thank you, Verena. Well, I've been working across the 5Ps of the healthcare system for the past 15 years. And my passion for changing healthcare by paying for value started when I worked at the University of Michigan Health Management Research Center. And they had a health risk appraisal that had collected data from the 1980s. And we were sitting in 2008. And the 25 plus years of deep data through culminated to then provide recommendations for individuals and populations on how to be preventive and be proactive with your health, and the actions you take was extremely powerful and instrumental. And this was the very beginning of my initial exposure and expertise in this space. And then it kind of culminated, fast forward 15-ish years, to having a child and being a patient, being pregnant, and then also delivering the child and realizing how
we met, right?
Yes, exactly. And realizing just what an empowering experience it is to be at the center of care and to feel empowered to say, I could say yes, I could say no. I received care in my own home. These are the very fundamentals that value-based care can bring. And I want others to be able to have this as their standard of care as well.
Okay, so I think that is still, but we should say we did some writing before, and you have done writing also before, so it wasn't totally a shock and new to you, I think, when we said
exactly.
we would be the perfect partner here to collaborate on the payer aspect. And I mean, you've been amazing because you shared your personal story, and we don't want to disclose it here because we want to motivate readers to get the book and read it and read on, like, particularly the hospital to home transition that we call like the triple H, right? So that is another important piece that we don't dive into too much today, but just to say that digital obviously is important for data sharing, etc. But we have another few examples in the book. I mean, what do you want to dive a little bit into one of those? Maybe I know one is called Jim and other things.
Absolutely. So I would say by reading this chapter specifically on payer, I see three key messages as really key takeaways. to empower you as someone who may be new to value-based care or even as an expert. So one is that value-based care allows for that N of one approach. We see that in the story that's Jim in this chapter. And this is literally the ideal example of something that could have been prevented through a health risk assessment
I
and
just
a
want to
tailored
disclose
care
for the
plan.
listener that it's a case of acute myocardial infarction, and that it's a very young patient. And we're not the caregiver of this patient or person or my nephew, but needless to say, our assessment is this could have maybe prevented by big chances. So to spark some curiosity, but it's a case of cardiovascular prevention.
Exactly, exactly. And he had a family history. You know, there are all of these risk factors that a health risk assessment would have caught had we actually been thinking about it from a holistic, person-centered approach. That's the foundation of value, and also the foundational to a payer to reimburse for. The second key message in this chapter is no one P can go at this alone. Payers need, they may have the more comprehensive data, they have the picture of the patient, but the provider is actually the one providing the care and is actually giving the recommendations and has the most impact in the patient in that way. So by combining forces and simply is going to create a much larger impact. And the third piece I would say, which is, you know, this is a standard piece, but we need to do this. You can't improve what you don't measure. So start measuring, start knowing where you stand, and do that with your payer provider, do that together. And we'll go into some more details and throughout this conversation. But Verena, I would love to put this question back to you. What do you see as the role of the payer across the value chain, and what are your key takeaways that you want the reader to have from this chapter?
And I want to bridge it back to your second point, and I'm almost going to call them the Siamese twins here for this chapter discussion. I mean, it's Siamese, I don't know, what is a five twins?
Quintuple.
So, okay, here we're focusing, it's really Siamese, and I think you said it, it's about the data and the data. And today they're absolutely in two silos. So the claims data, what the health insurance says, obviously is anonymized and has only certain, really minimal facts, and it's totally dissected from what the doctor sees that has a more holistic view, which many now will argue, no, my doctor only also has a siloed view. Okay, fair enough. But we're just comparing, your health insurance data and the provider data, and let's say a hospital maybe. So they have a much longer, if you're having a month's stay in the hospital, well, there's a wealth of whatever happened very holistically with this patient and this person for 30 days of stay in a hospital. But there's only pieces extracted that go to the health insurance. So it's very siloed. And I want to read one part of the chapter. And I think this is how you and I started when we started discussing the chapter, actually. One of the peculiarities of healthcare is that the buyer doesn't directly interact with the seller. So this sentence may speak maybe more to business people and MBA holders. But I think it's easy. Like when you go and buy new shoes, you go to the shop, you buy a pair of shoes and you sell it and you will be the one wearing it. It's like two people. And the shoe shop, is usually often also, the manufacturer of the shoes. So it's a very simple value chain. So what we're writing, what do you mean? As you've noticed in the preceding chapters, no doctor-patient relationship, no healthcare. So that's one duo. But the provider isn't the one who is selling. And the patient isn't the one buying. So I'm not going to the doctors and the doctor prescribes me my aspirin maybe. So the doctor hasn't produced the aspirin. And I'm not I could take a risk, prescription, go to the pharmacy, and then I get my stuff. But I'm not directly paying $10 for the aspirin to the doctor in this moment. That's what we need. So doctors are technically selling their services, like the consultation and the surgery, but they're not selling the much needed treatments, as I said, the aspirin, or more expensive cancer, chemotherapy, immunotherapies. These are then developed and provided, but what we read from Nienke before, by the pharmaceutical sector. So here we have our five, and then we're asking the question, so who the heck is paying? So, I mean, we're not diving into this now too much, but in my teaching, I often call it's a B to B to B to B to B to C business, right? So why is that an issue? The issue is today, everybody behaves like we are in silos. So the health insurance does their business, the hospital does their business, the patient just wants good care and is not, it's maybe paying premiums to the health insurance. But I think this is what I mean. And I think we haven't enough awareness and education maybe around that partnership. And this is why I think your experience here is so important. And maybe you can share with us a little bit more crisp detail on that payer provider. And I know you've worked particularly with hospital settings and large, what we call claims data sets on the health insurance side. So maybe you can shed some more light on if the reader, or the listener is interested to really learn more so that we can act better and bridge those gaps between those silos more.
Absolutely. Absolutely. Thank you, Verena. And I mean, honestly, like a lot of this isn't rocket science either. So our goal here in this book is to simplify that although this complex interconnected system feels like we can't get to the simple answer, we can. So this is where partnership collaboration is key. And this is what the payer provider can do together through contracting. The payer, as I mentioned before, the payer needs the provider and vice versa. So at a minimum, payers and providers can start working together by simply starting a conversation, by simply sharing data, and start with even a pool of your highest risk, highest cost patients. This is a win. This is something that's going to be a win-win no matter what, and also can have high impact on the bottom line of a provider and the insurer. That begins this relationship to then know, where am I? What am I measuring? What is my baseline? And that's when you can start considering capitation models that, like we discuss in the chapter, and also step into these are my basic performance and quality measures. Let me start, getting paid for those because I'm doing okay in those. And also let me start observing some of these other measures that are higher impact, but maybe harder to get to and take time. That then evolves. So trust is built between the payer and the provider. People are winning. The patient's winning. The payer's winning. They have more money. The provider is winning because they have more money as well. So you see, this trio. And from there, you can actually start thinking differently about your specific patient populations. And that's where we talk about bundles in the book. So the example we use is the bundled payments for care improvement advance. So that's the BBCI advanced program from it's in the United States, out of CMS. And this looks at patients in their 90-day post-acute period and is trying to essentially have the patient go to the lowest cost setting after they've been in the hospital. Because most patients want to be at home, but we need to facilitate their ability to be at home. If they can't be at home, they don't necessarily need to be in an inpatient rehab facility, but maybe a simple skilled nursing facility. So this actually looks at that cost in that 90 days through 34 different clinical episodes. And what's instrumental and why this program has been successful is because then there's data sharing from both CMS, from the Medicare Advantage payer, and also from the provider. There's collaboration with these post-acute spaces, with home health care if the patient's going home. You're looking at an expansion of discussion and meeting of minds to ultimately create the change.
Yeah.
So this requires change management at a minimum as well.
Thank you so much. And we have those really nice, I think, simplified figures. Again, for the expert, it might be too simplified, but I think with this book, our aim is to educate and help understanding with those who are maybe less expert in a certain sector. I want to say thank you for sharing that example from the US. And then many people also say, yeah, okay, the US, sometimes there's more progress than in other places. I want to say, no, there's a lot of pockets also in European countries. I have to say, in Asia, those people who follow the topic on LinkedIn, for example, there's people from Malaysia who are posting. So there, the thing is, it's still in pockets, and that's also our other objective with these books is just shared.
Mm-hmm.
I want to, like hot off the press from one country that I'm based in, Switzerland, has something very bureaucratic called Article 58. How fancy. But at the end, if you read it really carefully, it is a new law. It's legally binding. And the essence, it's a value-based contracting between, and the contract is signed between the representative of the payers, the health insurances in Switzerland, and the providers, in this case, the hospitals, so anything inpatient. And they're now obliged to measure what Kathleen said in her third principle. You have to start measuring, and we're not discussing the detail. Maybe we do a separate podcast on, on different laws in different countries. But one simple example, because I also want to say we have an updated table on the waste and the numbers, and it is still 30 to 50% of any country you look around the world. If you say whatever, Switzerland maybe has 100 billion per year healthcare expenditure, imagine up to 50% is wasted. Or in France, 300 billion. That means 100 to 150 billion in France is wasted that we could reinvest differently. And on the provider sector that Kathleen explained to us, for example, there's one line of research on low value care. Let's say there's one article also that just was published from Dr. Marie Meillon on transfusions. Who really needs transfusions? And that's what we mean. You need to start measuring. And then we start to see that actually too many patients get unnecessary transfusion. So it's the wrong care for the wrong patient in the wrong place, but still it's being paid for because the incentive is the service and you get it paid for the service.
Mm-hmm.
So once we do what Kathleen, you tell us to do, the payer and the provider partner, and they share data and they understand who is the high risk patient who really needs that transfusion. And then
Mm-hmm.
start understanding, well, all those other, like Kathleen, who just had a baby, maybe strong bleeding, but you know what? Her hemoglobin is actually pretty good. She's super fit. She is a runner. Yes, the guidelines say she needs transfusion, but you know what? Maybe we talk with her and maybe she says, no, I'll figure it out. I don't need it. That's what we mean with partnerships, right? And payers. So also, once again, thanks for sharing your personal story, because I think this is what our book, what readers like.
Yeah, it keeps it sticky. So we talked a lot about payer provider, Verena. I would love to hear your perspective from the pharma lens.
Yeah, I'll keep it really brief. And there's another really nice, that's that second figure in table, because the same thing. So it's about building trust between for-profit companies that develop new products, and that can be pharmaceutical, that can be medical device, that can be actually a digital application. It is true for anybody who develops treatments, in the for-profit sector. Start talking to the payer sector, be it a central payer in certain countries or to health insurances. But you need to partner early while you're developing your product, and don't look at them as a service provider, and don't finger point and say, greedy payers, they never give us a good price. Maybe that is true, but also don't miss the opportunity to build a partnership early on and help them understand the added value that your device or your drug will deliver to that population broadly. And then there's the same thing. You can do risk sharing agreements. You can do bundles. You can do certain ways of capitation. Say, the payer maybe pays 2 years of the treatment, and anything that's beyond, maybe the pharmaceutical company takes. So same principles apply. And I think what I experience often in my own past as a doctor and a pharmaceutical leader, but also now in the consulting work, is that we have those assumptions. and it's in our mind
Mm-hmm.
on good reasons and good legitimacy because we all have made bad experiences. Fine. I think what we're trying
Mm-hmm.
to push is the culture shift. It's like reset the button, read the book, see all the creative ideas that we can have, and start new and fresh and try it out.
Absolutely. Absolutely. As I always say, culture eats strategy for lunch. Oh. So culture is going to be
Breakfast, lunch,
key.
and dinner.
Yeah. Thank you, Verena. I think it's powerful because it's, yes, the same principles apply across, but you're also dealing with different incentives. And so being really intentional about what that means. And I think what this chapter and book does overall is make it very clear through each of the experts what the incentives are and why and and where to start aligning your own incentives with the rest of the four P's, so to speak.
Wonderful.
Fantastic.
So I think to conclude, because I think we said like why this particular chapter, you said it really nicely. We want to contribute and simplify. And maybe now that I think about it, also alleviate some of the anxiety and kind of that respect that we have. It's like, oh my God, I can't go and talk to the payer. You know, they're always so strict and it's all so serious and they never have leeway on their budgets. And what is it that I can do? That is our word of encouragement. Read the chapter within the 5 Tango book and let us know your ideas and let us know your questions. Thank you so much.
Absolutely. We would love to hear from you. And thank you, Verena, and excited to continue this conversation.